start, please.
Thank you, Dr. Yahya. Good morning, my teachers and colleagues. Today, I will be answering practice question 5 of the November 2021 National Postgraduate College exams. Am I audible?
You are. Go ahead, please.
Okay. So the question says, a patient presenting with shortness of breath, crepitations, he also had fixed splitting of the second heart sound and ejection systolic murmur, and was also discovered to have atrial septal defect. So these are the questions. One, what is the definitive treatment? And two, approaches to this treatment. Name 6 roles of cardiologists in preparing for surgery. And patient eventually had surgery. Which 6 other teams, apart from cardiologists, are involved in managing the patient? And then which other 6 investigations will you do? Name 6 non-doctors and non-nurses teams that are involved in managing the patient after surgery. So to the first question, the definitive treatment of atrial septal defect is atrial septal closure. And there are 2 approaches, the percutaneous transcatheter closure, which is an interventional procedure, and then the surgical closure. The roles of cardiologists in preparing the patients, cardiologists actually play a vital role in assessing the patients prior to surgery. Is the first patient likely to have encounter with the patient is supposed to take detailed history and examination to assess the extent of the disease and also to evaluate for other associated comorbidities, considering the fact that this is an adult patient, he may have hypertension and other background comorbidities. So it's the responsibility of the cardiologist for initial assessment. It's also the responsibility of the cardiologist to do echocardiography, transthoracic or transesophageal, to assess the size of the location, the site, and also the hemodynamic status. This will tell the likely procedure and also the prognosis of the intervention that will be carried out. And also the responsibility of the cardiologist is to also manage heart failure. We know that this patient can have right heart failure, they may have even congestive heart failure in the long term. So it's the responsibility of the cardiologist to manage heart failure, treat pulmonary hypertension, treat arrhythmias, because this patient is also prone to arrhythmias like atrial fibrillation. So it's the responsibility of the cardiologist to make sure that heart failure, pulmonary hypertension, arrhythmias are well taken care of prior to surgery, and also to manage other comorbidities with relevant specialists. The teams that will be involved in managing this patient, of course, cardiothoracic surgeon is the lead team. And then other teams that are also important in managing this patient include cardiac anesthetists, intensivists, electrophysiologists, because this patient is prone to cardiac arrhythmias, intra-op and post-op. So electrophysiologists, perfusionists with expertise in left ventricular assist device and extracorporeal membrane oxygenation. Nurses, cardiac, intensive care, and cardiac nurses will also play a vital role in managing this patient. Pharmacists, ICU, and theater technicians will also play a vital role in managing this patient. Other teams that are also important include social workers, psychologists, and also patient and caregivers need to be carried along from the onset of evaluation, bearing in mind the explanation of the disease, the options and prognosis. So they are also important and play a vital role in managing these patients. So 6 investigations, even though we were not told what was done to detect the atrial septal defect, but we know that echocardiography is the gold standard and is the initial tool. So likely this patient had echocardiography. But these are the investigations that will be needed in this patient: echocardiography, transthoracic or transesophageal. Transesophageal will help to delineate some other types of septal defect like the sinus venosus, and also will help to assess other associated congenital abnormalities that may not be detected with transthoracic echocardiography. Other investigations that are also important include cardiac MRI, cardiac CT, especially in patients with poor echo window, can also help to quantify the ventricular function and also the hemodynamic status, and also the viability of the myocardium. Chest X-ray is important. However, it doesn't really play a key diagnostic role, but it will show cardiomegaly, usually of right ventricular preponderance. It may show prominent pulmonary arteries, this patient is prone to recurrent infection. So you may see some features of chest infection. ECG is important because these patients are prone to arrhythmias, atrial fibrillation, and so depending on the patient you are dealing with, cardiac catheterization and exercise testing can be done in this patient. So these are the investigations that will be done. But then other investigations, the baseline investigations are also important. Renal function, lipid profile, fasting blood sugar, and other baseline investigations. So CIS-node doctors, non-nurses teams that involve pharmacists, cardiac physiology, social workers, psychologists, technicians, and caregivers are these 6 non-doctors that will play a key role in monitoring this patient. So this is how I will answer this question. Briefly, let me go through atrial septal defect under the following outline. Atrial septal defect occurs when there is failure to close the communication between the right and left atria. It encompasses defects involving both true septal membrane and other defects that allow communication between both atria. And it is the commonest adult congenital heart disease and the third most common cause of congenital heart disease that occurs in 56 to 100 live births in 100,000 infants. It occurs due to spontaneous malformation of intra-atrial septum. It can occur as a singular defect or associated with other congenital heart diseases, cardiac and other congenital heart diseases. And etiologically, it has been linked with Mendelian inheritance, transcription errors, mutational maternal exposures to toxins like alcohol, cocaine, and other teratogenic substances. And the important genes that are implicated in atrial septal defects are the GATA4 gene, TPX5, and NKX25 genes. These are genes that play a key role in atrial septal defects. The 3 major atrial septal defects account for 10% of all congenital heart disease, and these are the ostium secundum atrial septal defect, ostium primum, and sinus venosus. And as much as 20 to 40% of this congenital heart disease presented in adulthood. 75% of atrial septal defects are the ostium secundum type. They represent approximately 7% of all congenital cardiac defects, and 3 to 40% of all congenital heart disease in patients older than 40 years. Ostium primum is the second most common and account for about 15 to 20% of all cases of ASDs. And it is a form of ASD that is commonly associated with mitral valve abnormalities. It can also be associated with ventricular septal defects. Sinus venosus account for about 5 to 10% and may be associated with anomalous connection of the right-sided pulmonary veins. It may be associated with anomalous connection of the right pulmonary veins. So epidemiologically, ASD is commoner in female, with the female to male ratio of 2:1, and the timing of clinical presentation depends on the degree of the left to right shunt. Symptoms become more common with advancing age, and 90% of patients by the age of 40 years present with symptoms of exertional dyspnea, palpitations, and even heart failure. And about 90% of patients with mild defects, 75% with moderate, and 40% with complex ASDs may reach the age of 40 years. So the presentations depend on the size of the defect and the hemodynamic compromise. So this is just an overview of the embryologic development of the atrial septum. The septum primum is the primary intra-atrial septum developed from the roof of the primitive atrium, sorry, I'm trying to have a pointer, from the roof of the primitive atrium, it grows caudally to the endocardial cushions. So as it grows, there is a space in between the septum primum and the endocardial cushions. This is foramen primum. So this foramen primum will grow caudally and attach to the endocardial cushion, creating a septum between the right and the left atrium. So if there is a defect in attachment of this, the caudal end of the septum primum to the endocardial cushion, there will be formation of the septum primum, septum primum ASD. And then simultaneously, as the septum primum attached to the endocardial cushion, there is a degenerative changes that take place in the dorsal aspect of the septum primum, causing fenestrations that coalesce to form a defect called the secondum, foramen secondum, because of the fenestrated lesions that coalesce to form a defect between the septum between the dorsal part and then the caudal end of this distant septum primum, causing the formation of the foramen secondum. However, there is a development of septum secondum on the right side of the septum primum that also grows caudally, opposing the septum, the caudal part of the septum primum. So, however, during intrauterine life, there is a space in between these two septi because of the high right atrial pressure during the intrauterine life. The oxygenated maternal blood would flow pass through the foramen ovale. This foramen ovale is formed in between the septum secondum and the septum primum. So the oxygenated maternal blood will pass through the left atrium and ultimately into the fetal systemic circulation. So during birth, this because of the establishment of pulmonary circulation, there will be increase in left atrial pressure, and this foramen ovale ordinarily will close because of the increased left atrial pressure higher than the right atrial pressure. So, but in some individuals, because of the persistent increased right atrial pressure, this foramen ovale may be persisted. So some authorities consider it as a form of septum secondum defect. However, ordinarily, septum pattern foramen ovale has some argue that that has nothing to do with maldevelopment of the septum primum or septum secondum. So patent the septum secondum defect occur when there is excessive degeneration of the septum primum. Okay, so creating a space between the septum secondum and the septum primum, causing the septum secondum ASD, or when there is shortening of the septum secondum from the developmental process. So there will be failure of apposition of the two septa, causing a defect. So pathophysiologically, we know that sorry, let me pick a pointer. Okay, not very clear, but let me manage. So pathophysiologically, we know that the left cardiac pressure is higher than the right cardiac pressure. But in normal individuals where there is a complete septal formation, there will be there will be flow, a normal flow of the blood, the venous return through from the superior vena cava to the right side, the pulmonary circulation. But if there is a defect, because of the left atrial pressure that is higher than the left, there will be shunting of oxygenated blood to the right atrium through the ASD. So adding to the venous return, and then ultimately emptying into the left ventricle and to the pulmonary artery. So over time, because of the increased volume load, there will be some conformational changes because of the shear stress and then endothelial dysfunction. There will be some remodeling that will take place within the pulmonary artery and also the right ventricle. So what we expect in these individuals over time, there will be dilatation depending on the size of the defect. There will be dilatation of the right chambers, and also increase in pressure in the pulmonary artery pressure that is transmitted into the right chambers, such that the right-sided pressure is higher than the left-sided pressure, leading to a reversal of shunt. So when there is reversal of shunt, remember the blood in the right is deoxygenated. So there will be the reversal of shunt from the right to the left. So causing cyanosis because of the translocation, shunting of the deoxygenated blood to the left side of the heart, causing a complication known as Esimenga syndrome. So this patient may present with cyanosis and other So this is just a schema to explain the pathophysiology. Increased pulmonary blood flow causes shear stress, circumferential stress, endothelial dysfunction, vascular remodeling, increase in pulmonary vascular resistance, reversal of shunt, and Esimenga syndrome. So clinically, these patients, majority of them may present asymptomatic, and the presentation depends on the size of the defect. So patient with smaller defect less than 5 might not develop any symptomatology, while patient with defects ranging from 5 to 10 will present in the fourth or fifth decade of life. So a patient with larger defect may present earlier in the third decade of life, and the most common presenting symptoms in adult is exertional dyspnea, palpitation, cardiac arrhythmias. They may have syncopal attack. Some may present with stroke from paradoxical embolism or heart failure. Patient may present heart failure, and then they may have 30% of patients may present with exertional dyspnea by the third decade of life, and more than 75% of patients by the fifth decade will present with symptoms. So paradoxical embolism may be the first presentation in patient with atrial septal defect that will prompt the patient to look for possible causes, which is likely to atrial septal defect. So clinical features, clinically, this patient, depending on the severity and the hemodynamic compromise, finding on clinical examination, patient may be breathless, tachypneic, at rest with hypoxia, and the patient has a reversal of shunting. And then they may have pedal edema in right ventricular heart failure. They may have irregular pulse, because one of the complications this patient will have is atrial fibrillation. So they may have elevated JVP. APS may not be displayed because a primary cardiac, right-sided cardiac abnormality. So in most cases, there may not be epic displays apex. However, patient will have left parasternal hip because of the right ventricular hypertrophy and hyperdynamic states in the right ventricle. There may be palpable pulmonary artery. They may have loud P2. And they usually have wide fixed splitting of the second heart sound. Normally, the heart sound, pulmonary aortic, the second heart sound, we have the aortic and the pulmonary. During inspiration, usually aortic comes before the pulmonary because of the high diastolic pressure in the left-sided, the left ventricle. So the aorta will close, the aortic valve will close first before the pulmonary. So during expiration, it's just the pulmonary will close just after the aorta closes. So in inspiration, because of the increased venous return, there is normal physiological splitting where there is delay in close. So where the duration is a bit wider. So during inspiration, because of the increased venous return. But in ASD, because of the increased venous return due to shunting, the net effect of respiration is actually abolished. So there's wide fixed splitting throughout the phases of respiration, and this is very typical for atrial septal defects. Patient may have ejection systolic murmur because of the increased right ventricular stroke volume, and then they may have mid-diastolic murmur at the left parasternal area. This is because of the increased left ventricular filling, right ventricular filling, because of the increased volume that is passing through the tricuspid valve. Complications, right to left shunts, cardiac arrhythmias, pulmonary hypertension, right heart failure, paradoxical embolism, and recurrent infections. So echocardiography is the gold standard for imaging mortality in diagnosing this patient. It helps to detect the size of the defect, understand the direction of flow. You can also assess other congenital abnormalities, pulmonary artery pressure, and also you can also estimate the pulmonary to systemic flow ratio. This will tell us whether the patient is having right to left or left to right shunt. So if the ratio is more than 1.5, that is the pulmonary circulation, systolic flow is higher than the systemic flow. Using the echocardiography, is a formula to calculate that. So if the ratio is more than 1.5, it's significant left to right shunt. But if it is less than 1, it means there's a reversal of flow from the right to the left.
Dr. Abakar, please try to round up in the next 2-3
Okay,
minutes.
sure. Okay, so other investigations include cardiac MRI, CT, chest X-ray, exercise testing. Cardiac catheterization is very important, especially in patients with pulmonary hypertension. It can help us to directly measure the pressures and also assess the pulmonary vascular resistance. It can also help us to determine the treatment modalities. So management, conservative, medical, manage arrhythmias, hypertension, pulmonary hypertension, and other comorbidities. Then definitive percutaneous transcatheter closure and surgical repair. So I've already talked about. So medical treatment, intense treatment of arrhythmia, pulmonary hypertension, and other complications. Definitive treatment, like I said earlier, is the percutaneous transcatheter closure and surgical closure. And treatment is indicated if the patient has a paradoxical embolism with stroke, irrespective of the size, patient with hemodynamically significant shunting, and evidence of oxygen desaturation on exercise testing. So this is an algorithm based on management of atrial septal defect. If the right ventricular volume, you do after evaluation, assess the right ventricular volume. If there is no volume overload and there is no suspicion of paradoxical embolism, there is no need to close. However, if there is paradoxical embolism and the right ventricular volume is normal, the defect should be closed. On the other hand, if there is right ventricular overload, you subject the patient to cardiac catheterization. So if the pulmonary vascular resistance is more than, and then to check whether the pulmonary vascular resistance is more than 3 Wood units. If the pulmonary vascular resistance is less than 3 Wood units, and then you assess the left ventricular disease. If there is LV disease, if there is no LV disease, there is no need to close. Once the pulmonary vascular resistance is less than 3. However, if there is LV disease, you have to do balloon testing to see whether there will be decompensation, which is a temporary measure, to see whether there will be LV decompensation after closure. So you do that to weigh the benefit and risk and decide whether to close or not. On the other hand, if the pulmonary vascular resistance is more than 3 Wood units, but less than 5, so you treat the pulmonary hypertension. After treatment, if the pulmonary vascular resistance falls below 5 Wood units after treatment of pulmonary hypertension, if the pulmonary hypertension if the pulmonary hypertension does not fall below 5 Wood units after treatment of pulmonary, sorry, let me check. Okay, pulmonary vascular resistance falls below 5 units after pulmonary hypertension treatment. If no, there is no need to close. But if the pulmonary vascular resistance falls below below 5 Wood units after treatment, fenestrated closure may be done. This class 3B. But if the pulmonary vascular resistance is less than 5 units, closure should be done. So percutaneous transcatheter closure is the most preferred modality of treatment. It has less complication, and then there is no need to expose the patient to pulmonary bypass, pain, and thoracotomy star, and also has less hospital stay. Patient will be discharged within 24 hours of procedure, and it's indicated in septum secundum that is measuring 5 millimeters, between 5 millimeters to 32 millimeters, with significant LV shunting. However, there must be an enough rim to allow for placement of the septal device. It is contraindicated in hemodynamically insignificant ASDs, ostium primum septal defects, sinus venosus, coronary sinus defects, or in larger defects that are greater than 32 millimeters, or when there is inadequate margins to anchor the device. So these are the different types of devices that can be used. We have delivery cable, the right atrial disc, left atrial disc, and this is the procedure. Finally, the delivery device cable will be removed, and the device will be left in situ. So complications, arrhythmias, embolization, device erosion, device fracture, and thromboembolism. So when atrial septal defects are close percutaneously, patient require antiplatelet therapy for the subsequent 6 months. Women with large ASDs with AC-Menger syndrome should be avoid pregnancy due to risk of aggravating pulmonary arterial hypertension that may be present and increase the occurrence of arrhythmias. Surgical closure is a treatment of choice for sinus venosus, sinus pramum, and then coronary sinus defects. And 2 modalities, it's required either use a placement of patch over the lesion, usually in larger lesions, they're using pericardial or synthetic patch, or primary closure for a slit-like ASD with well-defined rim that will allow H2H application. So these are the differential diagnoses that should be considered. In conclusion, ASD common is adult congenital heart defects and can range from clinically asymptomatic lesions to lesions that cause pulmonary hypertension, cyanosis, and vascular complications such as stroke. Most small defects will spontaneously close within the first year of life. However, large defects associated with significant systemic pulmonary shunt and systemic oxygen desaturation require percutaneous surgical intervention. These are my references. Thank you for listening.
Well done, Dr. Muhammad Sani Abubakar. It's really a very good presentation. Thank you very much. I think we'll allow the floor for contributions. I just have noticed that, okay, sometimes we have to tailor our presentation towards like a general medicine presentation. You know, if we are talking to specialists in our field, we could add so many things that are for specialty. However, it's a very good one. Thank you very much. So we entertain contributions, please.
Okay, good morning, senior colleagues and colleagues. You did a very great job. Anything about congenital heart diseases are usually very, very complicated, but I'm so impressed about how you took your presentation. So I'm just going to add a few things to what you said, because you said most of what you're supposed to say. Okay, so basically for the ASD, we have different types, which you've actually mentioned, but we have different sites where you can find this ASD. So for the ostium primum, basically we see the defects on echocardiography around the base of the interatrial septum. Why? Because, you know, there's a problem with the defect actually is around the AV valve, you know, because there's a problem with fusion of the septum primum with the endocardial fusion. The endocardial fusion is actually what helps to form the AV valves during the embryogenesis. So basically the defects at the ostium primum is usually around the AV valve. So if you're looking at the interatrial septum, the defect for ostium primum is at the base, while that for the ostium secundum is at the mid aspect. You see it like when you do an echocardiography, you see that the defect is around the mid aspect of the interatrial septum, of which you've already mentioned the defect, how it actually occurs in your types of ASD. Then for the third one, the sinus venosus, is actually seen around the topmost parts of the interatrial septum when you do an echocardiography. Why? Because it actually lies around the entry of the superior vena cava, of which you mentioned that there's an abnormal fusion of the sinus venosus and the atrium. So basically, when you do an echocardiography, you see the defects at the top part of the interatrial septum. That's more like a sinus venosum. Then if you see the defects around the mid parts of the interatrial septum, that's like the ostium secundum. And then for the ostium primum, it's around the base, because the defect is around the atrial the atrial ventricular valve, that's the AV valve, is around there. And then most times the mitral valve is what is affected in ostium secundum. So in the site of the ASD, so that's how you actually know from your echocardiography. The mid part is the ostium secundum, the apical part, that's where you find the sinus venosum. And then towards the basal part where you have the AV valve, that's where you find the defect of the ostium primum. Then also, you mentioned that ASD is actually common in females as compared to males, but basically it's commoner in ostium secundum. Is in ostium secundum ASD, you find more of females being affected as compared to males. That's ostium secundum. Then also, within they are most times asymptomatic within the second to third decade of life, because the defects or the left to right shunt is usually not severe, but over time, once that becomes persistent over time, the defect becomes large. And when the defect becomes large, it becomes symptomatic, because patients who were initially acyanosis now start becoming cyanosed. Like you actually mentioned before now, that when there's a small left to right shunt, or when there's a small defect, normally the pressure on the left side of the heart is more than that of the right. But when the defect becomes large, what happens is that the pressure on the left side and on the right side become equal over time. The pressure on the right side becomes more than that of the left. So there's now a reversal of shunts, where we now have a right to left shunts, and then they now become what symptomatic, they now become cyanosed, because there's now a mixture of deoxygenated blood from the right side now getting to the left side. So over time, most times from their fourth decade of life, they now become what's symptomatic. But it's expected that if the defect doesn't close before 25 years of age, most times it doesn't close again. And it's expected that surgery should be done on such patients once the defect is not closed, because it becomes symptomatic over time. Then also, to add to it, in childhood, how you get to know that this patient may be having an ASD, just maybe a routine examination will pick up a heart murmur in a patient. And then when you do a chest radiograph in this patient, you can actually see that the right side of the heart is actually more enlarged as compared to the left, because there's shunting of blood from the left into the right, because somehow there's now a form of volume overload, because blood that is supposed to be injected through from the left ventricle into the systemic circulation, then is shunted from the aspect of the left atrium getting into the right atrium. So there's now a volume overload on the right side of the heart. So when you do a chest radiography, you notice that the right side of the heart is usually more dilated as compared to the left. That's a routine check. Then, as you mentioned earlier on, from age 40 years, 90% of them are symptomatic. Then from 60 years and above, 100% of them become symptomatic. Then again, on physical examination, you can actually notice a palpable pulsation on the pulmonary artery. Why? Because there's venous congestion, there's volume overload on the right side of the heart, because blood is now moved into the right atrium, and then it gets into the right ventricle, and then there's so much blood getting into the pulmonary vasculature, which will lead to pulmonary hypertension. And also you notice palpable pulmonary artery when on physical examination. Then you made mention of a white split S2. Normally we have what we call physiologic split S2, where you actually mention that the pressure on the left side is actually more than that of the right. Normally the pressure on the left is about 10 millimeter of mercury, while that on the right is 2 millimeter of mercury. So normally we have that split, that physiologic split S2, meaning that the aortic valve actually closes like 2 to 5 seconds before the pulmonary valve closes. So, but in ASD, what happens is that due to the volume overload, what happens is that the pulmonary valve tends to close slower than how it is supposed to close, because the volume is so much. There's volume overload on the right side of the heart. So there's now a widely split S2, meaning that the splitting now becomes wider than what it should be, because the pulmonary valve is now taking a longer time to close as compared to what it should be normally. So that's why we have that wide split. But normally we have what we call the physiologic split. where there's a little delay between the closure of the aortic valve and that of the pulmonary, but it's expected that both valves should close at the same time, but the closure pressure on the left side is higher than that of the right. So that's why normally the aortic valve closes maybe 2 to 5 seconds before the pulmonary valve. But in ASD, due to volume overload, there's a delay in closure of the pulmonary valve, which brings about the delay in the wide splitting of the S2. Then also, you made mention of they normally have this mid-diastolic murmur. Normally in diastole, what happens is that the valves are closed, the AV valves are closed. So at that point in time, there's the movement of shunting of blood from the left to the right. So, but in severe, you actually see that mid-diastolic murmur in severe left to right shunt. That's why you hear that mid-diastolic murmur. So that's actually what causes them. For the crescendo, decrescendo systolic ejection murmur, that is mostly heard when there's an increased right ventricular systole volume, meaning that during systole, what happens is that the valves are actually open. So the stroke volume is actually increased in systole. Stroke volume is the amount of blood that's ejected from the heart per cardiac cycle. So what happens is that it's accelerated because the volume of blood ejecting out from the pulmonary aspect of the pulmonary circulation is increased. So what happens is that we then have that crescendo, that's an increased intensity in systolic ejection moment because the volume is so much. So we have that crescendo, decrescendo systolic ejection moment. That's one of the things you can actually pick on physical examination. Then also for ECG, ECG can actually help us tell us the different types of the ASD based on the picture. For ostium secundum, you can have a right axis deviation, right bundle branch block, because mostly in ASD, we have more of the right side of the heart being affected because most of the blood is being moved from the left down to the right. So you have right axis deviation, right bundle branch block. But for ostium primum, I mentioned that for ostium primum, we have the AV valves being affected and mostly the mitral valve. So some form of the left side of the heart is affected. So for ECG, you can have left axis deviation alongside with a right bundle branch block. So if you see a patient with ROBB, right axis deviation, you should be thinking more of ostium secundum. But if you see a patient with left axis deviation and then a right bundle branch block with ASD, it's more of an ostium primum that this patient has. And for sinus venosum, what you notice is that there'll be an inverted P wave on lead 3. So that's how you can actually differentiate the different types of ASD using ECG. Then for cardiac and catheterization, it can actually help us to know if this patient has a sinus venosus, because in sinus venosus, what happens is that there's an embryological fusion of the sinus venosum with the atrium. So basically what happens is that the catheter just goes straight into the pulmonary valve from the right atrium. So once you notice that the catheter is being inserted into via maybe the brachial vein or which of the venous access.
Dr. Florence.
Yeah, hello.
Sorry,
yeah, good day.
We can't take this detailed discussion here. We don't have much time. We want to close the class, please.
All right.
Thank you so much. But you can just round up. We need to take another.
Okay, thank you. Then in rounding off, adding to your role of the cardiologist, the cardiologist can actually help us to know if this patient meets, if there's an indication for the surgery to be done, or if there are contraindications, because there's some contraindications where we cannot do a surgical intervention for this patient. And then there are indications. If this patient has a severe pulmonary hypertension, this patient at the moment will not benefit from the surgical intervention, because what happens is that there'll be a failure of the closure because the pressure on the right side of the heart is so much. So basically, what happens is that for you to do this, prepare this patient for either a percutaneous transcatheter closure, the pulmonary artery pressure should be less than 40 millimeters of mercury. So the cardiologist can actually help to ascertain if this patient will meet the criteria for the surgical intervention, or to rule out contraindications in this patient, like severe pulmonary hypertension and others. So that's what I can actually say for this. Thank you so much. Thank you. Sorry for wasting your time. Thank you.
Thank you, Dr. Flora. Thank you. I appreciate that. Oga Shitu, Chief Shitu want to address us again. Go ahead, sir.
Thank you. Thank you very much. I won't waste much time on this. Thanks a lot. Last
Sir, we can't hear you well, sir.
oh,
Hello? Is it better now?
Yeah, we can hear you now, sir. Yeah, it's better, sir.
Okay, good, lovely. Sorry. The last speaker, well done. You basically took us on a trip around cardiology. Two things. One is that they may not ask you for things that detailed.
Yes.
In this type of question, because it's a general medicine question. But it's important to know, and I like her confidence in talking about it. And this is a class where we actually promote that talking. So if you can give the information, yes, give it as seamlessly as that. But I just want to take us back a bit on something that is important for us as per general medicine. Please note that, of course, I'm sure we all know that the splitting occurs when the patients inspire, right? When they're taking air. So that difference in pressure is occurring when the patient is taking in air, so inspiring. Okay. Now, in an atrial septal defect, what happens is that that splitting is fixed. So whether the person is taking in air or breathing out air, the person's the split is there continuously, and you have a widening of a normal split when there is a pulmonary stenosis. I believe I'm not a cardiologist, but my general medicine knowledge, yes, is when there is a pulmonary stenosis. So please, in case they take us on a round trip around that, or that is what they show in the exam rather than showing an echo or something, okay? What happens is that in an ASD, there is a fixed split. So whether the person is breathing out or breathing in, there is a split continuously because of the, of course, increased pressure in the pulmonary bed, because of more blood flowing in that particular circulation because of the defect. That's what I just wanted to add. So we should keep that in mind. Thank you, Dr. Mohammed.
Thank you, sir.
The contribution to address us again. She's a cardiologist. Go ahead, ma'am.
Yeah,
go ahead, ma'am.
Thank you very much, Dr. Sani Abubakar, for that excellent presentation. But I want to call the attention of the class, please. We have 15 minutes for every presentation. So whatever you want to present, please, for the sake of time, and just limit whatever you want to discuss within 15 minutes, because other participants in the class may have something to chip in. So we have only 1 hour for this discussion. Regarding what Dr. Florence said, the normal is just a point of correction. The normal physiologic splitting between the aortic and pulmonary components of the second heart sound is about 0.2 second. That is about 20 milliseconds, not 2 to 5 seconds. That is even beyond the duration of the one cardiac cycle. Then again, with regards to the role of cardiologists in the management of this patient, there's also patient education. The cardiologist is the one that will discuss the patient, educate the patient, as well as counsel the patient and the relatives about the diagnosis. I think you forgot to mention about that. Then part of the team is also a psychologist. Sometimes the cardiologist, after education and counseling the patient may not be satisfied, or he may be psychologically disturbed. So it's important to involve the psychologist in the management of this patient. Thank you very much.
Thank you, Mark, for this addition. Thank you very much. I think I'll quickly read out the chat box before we move to the next, so that we can be able to take another presentation. Just to highlight more, sometimes our contribution should be tailored to this general medicine class, not a specialty based. In specialty, we expect a lot of details, but in general medicine, basic knowledge, maybe we have to tailor that towards our. However, all the contributions are noted; they are good. From the chat box. From the chat box, Dr. Mahmoudou said they can have platypnea or orthodoxia syndrome, most especially with patent forming of valve, as well as with intrapulmonary shunting or ventilation perfusion mismatch. I think in the absence of that, okay, there are other comments which, okay, Dr. Mahmoudou said, thank you for the presentation. They can have a cryptogenic or embolic stroke from paradoxical embolism, which the presenter has mentioned. So he also emphasized on proper education on the need, importance of good oral hygiene and prompt medical attention for infections to reduce the risk of infective endocarditis. antibiotic prophylaxis for 6 months after closure or previous IE. So these are some of the comments. I think we can move to the next. Dr. Abakar Sani, once again, thank you for the presentation. You can unshare so that we have 15 more minutes for the next presentation. Thank you.
Thank you very much.
Okay, Dr. Lalatu is going to take us on the second part of the presentation for today. Go ahead. You have 10 minutes for your presentation.
Thank you, Dr. Yahya, for the opportunity. Good morning, senior colleagues and colleagues. I will take the practice question 7. Says that in a phase 3 clinical trial compared the new drug Travis to bupropion in enhancing smoking cessation, which was organized by a drug company. What is the study design? To minimize costs, which other study design would you use and why? What are the advantages? What are the things that you will do to ensure validity and reliability? In the course of the study, you find out that some people wanted to continue despite the side effect of the drugs. Example, blurring of vision. What will you do? Which ethical principle will you apply here? In the course of the study, you find out that some people have already been on some form of medication in the past. What will you do to make your result more valid? Will you still recruit them? Mention ethical principles in research. So the type of study design I would do is randomized control trial. To minimize the costs, I will either use another alternative study design could be pragmatic trial. A pragmatic trial is to assess the real-world effectiveness of intervention in routine clinical practice setting, focusing on how interventions perform in everyday scenarios. So in the randomized control trial, we usually have a criteria for selection of the patients, and the criteria and the inclusion and exclusion criteria is usually very strict. And then there is a particular way we don't want them to take this particular type of medication, no this, no that, no that. But and then they will remain in that under that control for the period of the study. So for the pragmatic trials, they usually for this randomized control trial, the other patient, the cases are the one on the new molecule that we are reviewing, while the other ones, they are going to be on placebo or on another alternative study or alternative molecule that have been in use. So, but for the pragmatic trial, we allow them to go on with this medication, not under strict control, and we allow them to continue in the community, doing all what they are doing, like normal day-to-day activity. And then we compare them with another best of care medication that's being in use. Then the advantage of this is provide insight to the effectiveness in the real world setting, because there are no any restrictions to what they do or what not to do. They will continue with their normal day-to-day activity. Then it will be more generalizable and reflect the actual clinical practice for the pragmatic trial. Another study alternative that we can use in this group of people to minimize costs is non-inferiority study that aim to demonstrate the new intervention is not worse than the standard treatment by predefined margin rather than the providing superiority margin. The advantage for this is we compare the new treatment that would demonstrate useful for comparing new treatment when demonstrating superiority is not feasible. And this can show that a new treatment is comparable to the standard and may require smaller sample size, and therefore the costs may be reduced than in the case of control trial or superiority trials. And this is just brief a slide that compared the randomized control trial, pragmatic trial, and non-inferiority trial. For the purpose of randomized control trial, is to assess the efficacy and safety, while that of pragmatic is effectiveness, and for the non-inferiority to demonstrate that it's non-inferior to the standard based of care. Generalizability is high with pragmatic trial because when we finish the randomized control trial, the patient, when they start taking the medication, they will continue with their normal life activity too. It's more generalizable compared to even randomized control trial. And then for the control over compounding factors, randomized control trial has a very high control over the compounding factors, and it's moderate for inferiority, non-inferiority, and low for the pragmatic trial. In terms of cost and resources, it's very high in the randomized control trial, but it's moderate in the others. The ethical consideration concern about control is there in the randomized control trial and is minimal in pragmatic and reduced in non-inferiority study. What are the things that you will do to ensure validity and reliability? Reliability is talking about the results, the replicability of the result, while validity is talking about whether the tools we are using is actually measuring what we intend to measure. So to ensure validity and reliability, the factors to be used like implementing strict inclusion and exclusion criteria to ensure homogeneity among participants. Also, randomization is another thing to minimize selection bias, then blinding of the participants, investigators, and even outcome assessors to reduce bias. It would be double control, a double blind, or even triple blind, where the participant, the investigator, and the outcome assessor, none of them know who is in the control and who is taking placebo and who is taking the actual molecule. And then standardizing study procedure and data collection is another thing to ensure validity and reliability. And then prior conducting pilot study is another thing that will help us to actually reassess and update our protocol that will be used for the study. They say in the course of the study, you find out that some people wanted to continue despite the side effect of the drugs like blowing of bishop. What will you do? Which ethical principle will you apply here? So if the side effect like blurring of vision is not that unexpected side effect, and it's not at the level of adverse drug effects, so we can utilize the principle of respect for autonomy. Usually before the study is being done, we must have informed them about the various side effects that could happen and the consent for that. So when the side effects happen, and then we explain to them this is part of the side effect, if they involve, as long as it's not causing deleterious effect, then and they wanted to continue with the trial, then we respect the principle of respect for autonomy. This involves respecting the individual's right to make informed choice about the participation in the study. However, it is essential to ensure that participants are fully informed about the potential risks and benefit of continuing with the medication. Question 5, in the course of the study, you find out that some people have already been on some form of medication in the past. What will you do to make your result more valid? Will you recruit them? Yes, to enhance the validity of the result, participants who have been on previous medication should be thoroughly evaluated regarding their past medication, as long as in our exclusion criteria, we did not exclude those that are on another medication which has effects on cessation of medication. If it's not part of our exclusion criteria, yes, we can go ahead to recruit them. However, if it is explicitly stated in our inclusion or exclusion criteria that if somebody has been on another medication should not be recruited, then we will not recruit this individual. And if we are to recruit them at the end of the study, we do subgroup analysis or sensitivity analysis may be conducted in this subgroup. We said individuals that are on this standard of care, this is their outcome. Those on our new molecule, these are their outcome. And there are other people that are on other non-verified care, and this is their outcome. It will enhance our generalizability of the molecule. So mention the principle, the ethical principle in research. We have 4 major ethical principles: respect for autonomy, beneficence, non-maleficence, and justice. So I just briefly mentioned a few things about clinical trial. It's a systematic study of pharmaceutical product in human subject to discover, verify, and identify any adverse reaction to the product and to study the pharmacokinetic and pharmacodynamics property of the drugs. These are the phases of clinical trial: phase 1, 2, 3, and 4. Phase 1 aims to establish safety and study the pharmacokinetic and pharmacodynamics of the study. The first trial of the new active substance carried out in healthy volunteers, usually about 30 individuals. For phase 2, aim to determine the therapeutics activity with limited number of patients that are suffering from the disease, usually less than 100 patients. For the phase 3, it's a large patient with the purpose to determine the short and long-term safety and efficacy profile of the medication. At that point, usually license is obtained for the trial. And the phase 4 is the first marketing surveillance for other not previously recognized side effect and the long-term efficacy for the medication. Also consideration for inclusion in combination therapy with other medication. Thank you very much.
Thank you, Dr. Dalatu. It's a very good one. The information has been communicated. Thank you very much. We entertained contribution comments from us, from our seniors, and from our teachers. Thank you. So far? Okay, go ahead, sir. Thank you, sir.
Okay. Good morning, Dr. Mohammed. Well done to the presenter for being fast and being straight to the point. Yes, you have the general grasp of clinical trial. I just wanted to throw in 1 or 2 things to help out a bit. Usually phase 1 clinical trials, the main thing is for you to find safety. You want to know at what dose do you see certain side effects and what side effects are there, and all of that. And of course, on normal individuals. Usually, the pharmacokinetic, pharmacodynamics of the drug may have figured out, and of course, mode of action of the drug may be figured out in what we call phase 0. So phase 1 is mainly for safety, to figure out what side effects may happen and how the body would respond to the drug. So that's why you're using normal people to figure out that. Yes, they could still get some more information about the pharmacokinetics and pharmacodynamics of the drug in phase 1 clinical trial, but that is not what it's actually meant for. And an easy way to remember the number of participants you need in phase 1, phase 2, phase 3, and all of that is phase 1 is in 10. So 30 to, some will say 30 to 50, some will say 30, fine. Okay, by the time you get to phase 2 clinical trials, you're actually trying to see if the drug can do what it's supposed to do. In this case, stop people from smoking or help people stop smoking. So here you take hundreds of people, okay? So you take people in the hundreds, usually maybe about 100 to 300 or thereabouts, okay? And here you're using people that actually have the problem. So here are people that actually smoke to see if the drug does what it's supposed to do. Now, by the time you get into phase 3 clinical trials, what you're doing, and that's what this question is. This question is actually a phase 3 clinical trial because you're comparing the drug with something else that's already in the market to see if it can do what that drug does in the market, that drug that's already in the market does, or even do it better than it. Okay, so that's why you're doing the phase 3 clinical trial. And here you use thousands of people. So 1,000 to 3,000, some books will say. Okay, and of course, the stage 4 is the post-kit surveillance, post-trial surveillance. Okay, for you to figure out issues even when the drug has entered the market. Okay. Yes. Now, for the question that talked about the patients that are having side effects that want to continue with the trial. Now, there are several things you need to put into play. I know you used autonomy as the only ethical principle you would want to use here, but I think you may have to use more than just autonomy. Autonomy is the fact that, yes, the patient still wants to continue with the trial, okay? But you also have to look at this. Is the drug doing what it's supposed to do for the patient? Meaning, is the patient benefiting from the drug, so beneficent as well? And then what are the long-term side effects? What are the issues you may have long-term? Okay, or how bad is the disability caused by the blurring of vision? And that will be non-maleficent. So when if the patient insists on continuing on the trial, you have to look at all these things. One is that, okay, fine, you have noticed that the person has presented that, look, I have blurring of vision because I'm on this drug. First thing you want to look through the data. Is the patient doing well on this particular medication that the person is receiving? Now, if it's a blind test, you may not know which side of the divide the patient falls on. Okay, so you now ask yourself, oh, what is this patient? Is this patient having the effect of whatever drug he's taking? Now, if the patient is not having any effect, meaning the patient is not getting better, okay, or the patient is not helping the person cease smoking or stop smoking, then you start asking yourself, can I still continue on this drug? The person is having side effects and he's not getting any benefit from it. So why should I continue with the trial with this patient? Okay. So why not move the patient to the other arm of the trial and then continue on that? Since the patient still wants to continue and all of that, that's one option you can take. The other thing is, if the patient, how bad is this patient's disability? If it's just a mild blurring of vision, okay, it doesn't disturb things like his walk, it's not enough to disturb driving, it's not enough to disturb other things, and it's not progressively worsening, you could actually leave the patient alone and tell him, look, this is a side effect. Maybe what we'll do is reduce the dosage you are taking and see if it gets better. But of course, if it's getting worse and the patient is not, doing well on it, then you may have to either switch the patient to the other side, or that there isn't a side effect of blurring of vision, or take the patient out of the trial completely, because if you leave the patient there, then you're doing harm. Okay, so you may have to also look into that as well. So I think you have to look at those three things. You have to look at those three principles when you are looking at whether the patient will continue or not. And continuing will depend on, like I pointed out, one, the patient's decision, which you have already gotten, that the patient wants to continue. Two, is the patient benefiting from whatever medication is on? And then three, how bad is this disability that is receiving in form of the blurring of vision? How bad is it? Okay, and is it getting worse? Then that will help you make your decision on what you can do. And then the decisions that can be taken are: one, leave the patient if the patient is not doing too badly. Two, move the patient to the other arm of the trial if the side effect is only limited to the side the patient is on. Or three, take the patient out of the trial completely for his own benefit, because whatever is going on is something that may cause long-term damage. Okay, so I think those are just my contributions, but you did very well. Well done.
Thank you, sir, for the contribution and clarification. We really appreciate.
Thank you, sir. Dr. Fatima, Chief.
Yeah, well done, Dr.
Your contribution, sir.
for
Thank
that
you.
excellent
Thank you.
presentation. Yeah, I have an addition regarding the things that will ensure validity and reliability. Another important thing is to use probability sampling in selecting your patient, like a random sampling of participants. That will also enhance validity and reliability, as well as stratification where you stratify your participants according to maybe income level, education level, or based on some that have a particular habit or not, like cigarette smoking or not. Then again, use of multiple logistic regression to roll out confounders when you come to analyze your data. That will also enhance reliability of your result. Then regarding the other option, there is a question on if you want to minimize cost, which other design will you use and why? Then the advantage. I don't know, there is what I used to know, mixed treatment comparison, where you compare clinical trials of the old and new drug trials that are done separately on the new drug and the one that is done on the old drug, then you compare them. That is the mixed treatment comparison trials, though is highly unreliable. But I just want to ask, is it the same as the pragmatic trial you mentioned or not? Thank you.
Thank you, Ma. Thank you for the question and the contribution. Thank you. Dr. Dalhatu, can you respond to what Ma has asked?
Big people are asking questions. This one for small. Well, but I think the one you mentioned, is it mixed trial?
Treatment comparison, mixed treatment
comparison
versus pragmatic that you mentioned.
What I know, the pragmatic trials, you just for the randomized control trials, you restrict what patient eats, what patient does, and I think the movements. So many things is being restricted. So you don't allow them to run their normal life activity, so that you ensure anything that can have effects on the either pharmacodynamics or pharmacodynamic or pharmacokinetic of the drugs, you don't allow them to go into it. So there are a lot of restrictions in randomized control trials. But for this fragmented trial, you waive all those restrictions. So you allow patient to continue whatever he's doing. There's no much restriction about it. So they run their normal, so as if it is normal life. But for the other one, actually, I've not come across it. Thank you, Ma. And thank you for the additions.
Thank you, Dr. Dalhat. I think it's high time to hand over to our teacher, Chief Dr. Christabel, whether she's around.
I'm around. That's yeah. Thank you.
So, yes, ma'am.
Is it because I've been quiet? You guys have been making sense. It's not, you don't speak because you must speak. You speak because there's a reason to speak. So you must appreciate the first speaker. It was quite a lucid presentation. It was so detailed. And once again, I must appreciate Dr. Florence Kalamama. Wonderful attitude, wonderful lady, so stuffy. Thank you so much for your contribution. Really, we appreciate. I like it when people contribute this way.